What are the solutions that are possible, if there are any?
Well, I think we have to take a short-term view and a long-term view. The short-term view is let's get the exchanges working better. That really requires 2 or 3 major changes. One is to guarantee the cost-sharing subsidies. Another is to get this this reinsurance policy for health insurers. A third is to enforce the mandate. Those 3 things are actually going to do a lot to stabilize the exchanges and actually bring premiums down because they give the insurance companies more stability.
Okay,
the longer-term view is about affordability, and that requires us to change how we pay doctors and hospitals so that they actually want to get rid of unnecessary care. They're actually going to make care more efficient. They're going to bring down the prices of devices and other surgical procedures. And that is if we really want to talk about helping the American public, it's the affordability issue that most Americans are really focused on. So we got to do a short-term thing and a long-term thing.
Mark, does that sound reasonable? Does that sound workable?
Well, I think stabilizing the insurance market sounds reasonable, but notice that's occurring because we're in a bailout situation, Bill. Why are we in a bailout situation? Dr. Emanuel and I have talked about this before off camera. It's because almost 7 million Americans chose to take the tax penalty. You know why? Because they were too healthy, and most of them are under the age of 35. You know why, Bill? Because they know they can wait till they're sick and sign up then. So they do a little math and say, I'll wait till I'm sick. Then Aetna says, wait a minute, 55% of my new clients here are already sick. I'm going to drop out of the exchange. And the more that happens, the more premiums fly up. And we saw in 19 states last year 20% increased premiums. Now, you can fix that, I agree, by throwing more money at it, by reinsurance, by enforcing the mandate. Here's another way you could fix it.
Is it always money?
That's the point, Bill. It isn't always money. Why don't we say to young people, we're going to offer you a catastrophic option just to get you in the game? Why don't we say to young people, we'll charge you less money if you get in the game? Why don't we say to young people, we're not going to penalize you. We're not a country of penalties here. And let's fix the doctor's office, by the way, where doctors say, hey, nobody's paying me more, Bill, for all this computer time I now have mandated. I don't have malpractice reform. By the way, where did we get the idea in the United States that insurance means health care? Insurance can turn down the very health care it's promising you. It can say, sign up here, but when you get to the doctor's office, we're not going to cover that procedure.
I've heard you talk that way for 9 years.
Or if you have a large deductible, you may have a thyroid problem, or you may have pneumonia, and the patient says to me, hey, I didn't use up my deductible yet. I can't afford that chest x-ray out of my pocket.
The reason we wanted to do this segment is because of a comment that Chris Wallace had with Nancy Pelosi on Sunday when this exchange happened.
Enlarging the pool, making it healthier, younger, and having more benefits in the rest.
I understand the reasoning and I understand the history, but it doesn't sound like you're willing to give anything.
But it's not a question of that. What do they have to offer? In other words, you have to have a big pool.
There are Democratic congressmen already talking about resisting, Zeke, is not enough. You have to arrive at solutions.
It's not talking. Wait a second. It's not talking now. I've been talking to the Democratic congressional side and the Senate side, and they've been very interested in bipartisan agreement. Mitch McConnell did not reach out. He just had his 13 people behind closed doors. The president hasn't called anyone, either Nancy Pelosi or Chuck Schumer. Bipartisanship, they've been very interested. I do think one area we might have some overlap is what I've been calling auto-enrollment, where people get auto-enrolled into a particular program that the subsidy covers it. It sounds like there is some Republican interest. Senator Cassidy was interested, and a few of the more conservative think tank health policy experts are interested. That's an area where we could have overlap, and it would go to exactly what Mark is suggesting, some way of getting more young people, more healthy people into the insurance game and beginning to have that experience and understanding that it's actually to their advantage to participate.
Well, I think that he's right in the sense that we need to get more young people in by offering them more scaled-down catastrophic options at a younger age that they could then pay less for because they're signing up earlier. Another way to reach across the aisle is on Medicaid, and I think Dr. Emanuel and I agree on that. The Medicaid expansion is popular in all 32 states where it's been expanded. I would work on trying to keep it now. That's a way to work across the aisle, but scale it back. Recognize that 9.5% of the federal federal budget is too much towards Medicaid. Work on scaling it back. People don't want to lose an entitlement once they have it. They don't want to lose coverage once they have it.
We've seen that. Siegel, you write in
one
USA
area on Medicaid,
I want to squeeze in these two comments from Siegel, then I'll give you a chance there. You write in the USA Today, Obamacare added more cars to the train, but there are fewer engineers to drive it. Here's another line from your piece. I have a Cadillac health insurance plan in a land of jalopies. How is that fair? Zeke, go.
Well, first of all, I don't agree with Mark about the doctor shortage. We published a very detailed article in JAMA where we actually looked at the number of primary care doctors we need in the United States, given actually quite generous amounts of time with patients. We have more than enough. It's not a numbers problem. It's a problem of management.
Wow.
We have a lot of mismanagement of doctors' time. One of the things I point out in my new book, Prescription for the Future, is that actually changing how you schedule patients can increase the amount of time doctors spend with sick patients and actually make the physician's office more efficient and decrease emergency room use. It's those kind of management changes that we really need to institute.
Interesting answer.
And the way to get there is to incentivize doctors differently. Again, here I think Mark and I agree. We've got to pay them in a different way, not just for each thing they do, but more like capitation. Take care of the patient. Here is the annual amount you're going to get.
Okay, 15 seconds. I'm sorry, I'm almost out. Mark, go.
Bill, I do think there's a doctor shortage. The Association of American Medical Colleges says we're 100,000 doctors short over the next 10 years. I agree with Zeke about management of time, but the problem is we've computerized everything and doctors are overwhelmed. I work in a doctor's office. I spend 20 minutes seeing the patient, then 20 minutes writing about it. We need more nurse practitioners. I agree with him on that. We need more efficiency models. I agree with him on that. I would pay for quality care, but doctors' time is also worth something. I wouldn't take that away. Let's pay doctors for their time.
Look at this bipartisan agreement. I think this is a model, actually. Mark and I can agree on a lot of things. We may not agree on everything, but that gives you a bipartisan model that we could go forward with nationally.
We don't want to live in a land of jalopies, do we,
We respect each other, Bill, and that's where it starts.
Marc Siegel, Zeke Emanuel. Thank you, gentlemen, to both of you. Thanks.
Thank you.